السلام عليكم طلابنا طلاب المرحلة الخامسة. إن شاء الله اليوم ندي في أول محاضرات النوز اللي هي عددها 8 محاضرات. المحاضرة الأولى راح تكون about the congenital anomalies of the nose and the nasal trauma. About the congenital anomalies of the nose, we are going to discuss the choanal atresia and the congenital nasal masses. Choanal atresia is incidence about 1 per 5,000 to 7,000 live births. It affects females twice as often as males, and it is usually unilateral. Etiology, it is, as you know, during development there will be a primitive bucconasal membrane which separates the posterior choana from the nasopharynx. This membrane will involute during embryological development. Failure of involution of this primitive bucconasal membrane will lead to the obstruction of the posterior choana, which is called the choanal atresia. Regarding the types of choanal atresia, it is either bony, membranous, or mixed, which is the most common type, about 70%. Choanal atresia, it could be complete unilateral, which is the most common type, and it could be complete bilateral or incomplete unilateral and incomplete bilateral. This is a CT scan. As the cursor show, there is on the right side obstruction of the posterior choana. As we see, there is bowing of the lateral nasal wall on the right side. Also, the other picture is the endoscopic appearance of the choanal atresia. Clinically, as we said, it is more common in female than in male. Regarding clinical features, we divide the clinical features whether it is unilateral or bilateral. In unilateral choanal atresia, it is usually presented later in the childhood or even in the adulthood. This is because the patient has the other side of the nose can breathe through. There will be unilateral nasal obstruction and excessive tenacious glue-like nasal discharge, which is also unilateral. And bilateral choanal atresia, which is almost always present as respiratory emergency at birth. As a result of the nasal obstruction, and as we know, the neonate is an obligate nasal breather during the first 3 to 5 months of life. So the neonate will demonstrate cyclical changes in the oxygenation. When he cannot take a breath through the nose, there will be cyanosis. And this will allow the child to cry in order to take a breath, and so he take a breath through the mouth, and the pinkish color of the face return, and the infant will return quiet, and later on the cycle will be repeated, because when the mouth is closed there will be no further breathing, and also the child will tend to cry and to take a breath through the mouth, and this is act as a vicious cycle. Choanal atresia may be associated with other congenital anomalies, which is abbreviated as the CHARGE. The C is for colobomatous blindness, the H is for heart disease, A for atresia of the choana, R for retardation of the growth, the G for genital hypoplasia in males, and the E is for ear disease. So in any infant with any congenital abnormality, we have to seek for congenital abnormalities in other areas of the body. For diagnosis of choanal atresia, we can use a small flexible endoscope. If it cannot pass through the nose to the nasopharynx, means that there is a choanal atresia. Also, a small plastic catheter like the NG tube, neonatal, also cannot be passed through the nose to the nasopharynx. Cotton wool also can be held close to the nostrils, and we see that there is no movement of the cotton wool, which means that there is complete obstruction of the choana. And CT scan is important to see the thickness of the bony atresia, and the choanal atresia is diagnosed in CT scan if the choanal orifice measures less than 0.34 centimeter, or if the posterior vomer measures greater than 0.55 centimeter. Treatment of choanal atresia is divided into emergency and definitive treatment. The emergency treatment it is required in bilateral choanal atresia to maintain the airway by neonatal Waters airway. The definitive treatment which is needed for bilateral and unilateral choanal atresia is by surgical removal of the atretic plate by either transnasal approach, which is used when the atresia is membranous or thin bony plate under direct vision by using the endoscope, or transpalatal approach, which is used when the atresia is unilateral and thick bone in older patients. We finish the choanal atresia and we come to the other topic in congenital nasal diseases, which is the congenital nasal masses, which include first the nasal dermoid. Dermoids are formed as a result of sequestration of the epithelial elements during fusion of the medial nasal processes. They present as solid masses or cysts occurring anywhere in the midline of the nose, and they may also present as sinuses, which is recognized by minute opening, sometimes this opening containing hair. The treatment is of course by surgical excision of both the sinuses with the hair and the mass itself. This picture shows the dermoid cyst when there is sequestration of the epithelium during fusion of the medial nasal processes and formation of the dermoid cyst. The second congenital nasal anomaly is the nasal glioma, which is usually diagnosed by or seen after birth. It could be extranasal in 60% and presented as a cutaneous mass to the one side of the nasal bridge, while the nasal dermoid is on the midline of the nose, while the nasal glioma, when it is external, will be to the one side of the nasal bridge. Or it could be intranasal in 30%, which is causing nasal obstruction, or it could be combined extra and intranasal in about 10%. The treatment, of course, also by surgical excision. This picture shows the nasal glioma. The third congenital nasal mass is the meningoencephalocele, which are local herniations of the glial tissue and meninges through a defect in the skull base. They contain CSF, so injury to them may cause CSF rhinorrhea and sometimes meningitis, so we have to avoid puncturing the meningoencephalocele. This meningoencephalocele is connected to intracranial cavity so that they increase in size during crying, and it may present as a cystic mass over the root of the nose or intranasal mass. CT scan is very necessary in any mass in children, in infants. This is in order to see the exact size of the bony defect, and also to see if there is intracranial connections or not, because if there is intracranial connection, we need a neurosurgical cooperation with the neurosurgery in its management. The treatment, of course, also is by surgical excision. This is the extra nasal encephalocele, herniation of the glial tissue and the meninges through a defect in the skull and to the nose. Could be extranasal and could be intranasal. Now we come to the other important topics in the nasal diseases, which is the nasal trauma. And we are going to briefly describe two important diseases, which are the fractures of the nose, which is very common, and the septal hematoma, which is also a common disease. Regarding fractures of the nose, it is classified into type 1, 2, and 3. Type 1, which is the simplest one, which is due to a frontal or frontolateral trauma, and there is a vertical fracture of the nasal septum, which is called chevalier fracture, which runs from the maxillary spine to the nasal bones. The thin distal portion of the nasal bone is depressed or displaced, or actually it is depressed, and so it is this type 1 fracture is also called the depressed fracture. The chevalier fracture not occurring in all cases of type 1 nasal bone fracture, but it occurs in severe type 1 nasal bone fracture. Type 2, unlike type 1, it is due to a lateral, not a frontal trauma, and there is a fracture of the nasal septum, which is common, which is called the gingival fracture, which is C-shaped fracture of the perpendicular plate of the ethmoid and the quadrilateral cartilage. The nasal bones here not depressed, but they are displaced laterally, but not very gross, but not depression. It is displaced. Also, there is a fracture of the frontal process of the maxilla. So there will be fracture of the nasal bone, a fracture of the nasal septum, which is gingival fracture, and a fracture of the ascending process of the maxilla. Type 3 fracture, this type is actually due to high velocity trauma, as in RTA. And there is involvement of the orbito-ethmoidal complex. So there will be a gross depression, and the perpendicular plate of the ethmoid rotate backward, which results in a forward directed nostrils, which is called big-like appearance. Here, as we see the gingival fracture in this picture, and also we see the chevalier fracture in this picture, which is which are fractures of the nasal septum. Here is the picture of the nose. We see that in type 1 fracture, the fracture will be in distal portion of the one nasal bone, which is the breast fracture, while in type 2 fracture there will be fracture of both nasal bones, also of the distal portion, but the fragments will be displaced and not depressed. Also in type 2 we see there is a fracture of the ascending process of the maxilla. Here we see type 2 fracture. Why type 2? Because there is apparent deviation of the nose, and when we see, we want to see if there is asymmetry and deviation of the nose. We see it from front or we see it from above. Clinically, the nasal bone fracture actually presents with deformity, with rapidly developed edema of the nose. There may be black eye also in especially in type 3 fracture, pain and epistaxis with nasal obstruction. The use for diagnosis is mainly clinical, and the use of the X-ray, it is we order for X-ray of the nasal bone, lateral view. It is for medico-legal purposes, but it is of no importance clinically, and mainly the diagnosis is clinical. Regarding the treatment, first we have to treat the soft tissue. So actually if there is a fracture of the nasal bone, especially by sharp objects, there may be wounds. So we have to clean the wound and close it by sutures. Also tetanus immunization, and ice is used to reduce swelling. Regarding the nasal bones, if the patient presented early within 1 hour before the appearance of the swelling, so we can reduce the fracture immediately. But usually the patient presented later on and there will be edema over the nose, so we cannot determine the shape of the nose and the nasal bone if there is a fracture or not, and if there is a fracture, the edema obscure if there is deformity of the external nose or not. So we wait for 7 to 10 days in order the edema. Usually we wait for 5 to 7 days in order the edema to settle, and we can assess the nasal bone and if there is deformity or not. Because if there is no deformity of the external nose, and even if there is a fracture, then we not need to reduce it. Only we can put POP. But if there is displacement, so we have to replace it, the nasal bone fracture, and then put POP and nasal pack. Actually, when the fracture is left to be reduced after 7 to 10 days, we have to give a topical vasoconstrictor also in order to improve the nasal airways, and also we prescribe analgesia. The maximum time allowed for reduction is up to 3 weeks, because after 3 weeks there will be more callus formation, which make the reduction is unlikely to be successful. احنا بالحقيقة عندما do the nasal bone reduction of nasal bone fracture, we try to refracture the nasal bone. At which side? Usually the refracturing will be at the site of the fracture itself, and then we manipulate the nasal bone to put it in the correct position. So after this nasal bone can be fractured at the same site of the fracture itself within 3 weeks, because this callus is not strong. But after 3 weeks the callus will be very strong, and when we attempt to refracture the nasal bone at the fracture site itself, it will be very difficult, and usually the process will be unsuccessful. In type 1 fracture, we can reduce it by digital pressure or by Wilson forceps or by elevator. In type 2 fractures, we can reduce it by the nasal bones, actually by a Wilson forceps. In type 3 fractures, which is a severe fracture, so we need open reduction and internal fixation. This is the Wilson forceps, which is used for reduction of the nasal bone, and this Ash forceps, which can be used for straightening of the septal fracture. Also, these pictures of the Wilson and Ash forceps. The complication of nasal bone fracture, first deformity and nasal obstruction, also can cause CSF leakage in type 3 fracture. Orbital complications also in type 3 fractures, which is the telecanthus epiphora due to the damage to the nasolacrimal duct. Also, there may be important thing is to look for septal hematoma, because when there is septal hematoma, the urgency of septal hematoma is more than the urgency of the nasal bone fracture itself. Also from the complications, septal deviation and anosmia. Regarding septal hematoma, which is one of the complications of the nasal bone fracture, it is defined as collection of blood beneath the mucoperichondrium or the mucoperiosteum of the nasal septum. Usually it is due to a trauma, and it could be due to nasal bone fracture actually. Very rarely it is spontaneous, especially in those with a bleeding tendency. Pathologically, there will be submucosal blood vessels torn and the mucosa remains intact, resulting in hematoma formation. There may be a septal fracture and the blood passes from one side to another side, resulting in bilateral hematoma. The blood accumulates in the subpericondylar layers, interfere with the vitality of the cartilage, will lead to cartilage necrosis and sudden nose, so that the hematoma should be treated immediately. Also, the collagenase enzymes increase the rapidity of the cartilage necrosis. This picture shows this is the septum, and this is the mucoperichondrium. This is the mucoperichondrium over the septum. The collection of blood will be between the cartilage and the mucoperichondrium, and so it will separate the mucoperichondrium from the cartilage, and the cartilage actually depends on the mucoperichondrium for the nutrition. So this will lead to the deprivation of the cartilage from the nutrition, and it will lead to necrosis. In addition, the pressure of the blood on the cartilage will lead to necrosis, and the collagenase enzymes, which are also increase the rapidity of the necrosis of the cartilage. And the cartilage of the septum actually it is when it is necrotic, it will lead to the depression of the dorsum of the nose, and this is why the septal hematoma should be treated urgently. The same picture showing the septum, the mucoperichondrium, and the collection of the blood. The signs and symptoms including the nasal obstruction, which could be unilateral or bilateral, whether the hematoma is unilateral or bilateral, discomfort but not severe pain. On examination, there will be smooth rounded bilateral septal swelling, which can be confirmed by probing, which is compressible by probing and by aspiration. Usually the swelling is soft and in the anterior part of the nasal septum. And if we want to confirm diagnosis, we can take a probe, Jobson-Hose probe, and press the swelling to see if it is compressible or not. This is septal hematoma arising from the medial wall of the nose. The treatment, if the septal hematoma presented early, so we can do surgical drainage of the hematoma to reduce the risk of the cartilage necrosis by using incision, section of the blood, and put a drain, and the unpacking of the nose. Aspiration, the main treatment is the surgical drainage, but aspiration sometimes can be used in the early small hematoma under complete aseptic technique by a wide bone needle, which we may need to repeat the procedure. But the main procedure, the best procedure, is the surgical drainage by incision. Antibiotic used to prevent infection. Complications include external nasal deformity, as we said, when there is necrosis of the cartilage, there will be saddling of the dorsum of the nose. So there may be a sudden nose. Also in children, there may be affection of the facial growth and facial asymmetry later on. Septal thickening. Also septal abscess, because the blood is a good culture media for bacteria. So if there is infection of this collected hematoma, will lead to septal abscess, and this can be we can diagnose it by the appearance of fever and by appearance of pain, which means that the hematoma changed to abscess and we need surgical drainage, and actually also the use of the injectable antibiotic. When the also septal perforation, this is due actually to the necrosis of the cartilage. And as the nose is connected to the intracranial cavity by the valvulus facial and ophthalmic veins, so the infection when occur, such as septal abscess, it can spread to the intracranial cavity, and this may lead to cavernous sinus thrombosis, meningitis, and brain abscess. This picture showing the saddling of the nose due to the necrosis of the underlying cartilage due to septal hematoma. وشكرا جزيلا، وإن شاء الله نشوفكم نلتقي في المحاضرة القادمة بإذن الله.